Okay, cool. Let's
From the
go from the
top.
top. Yeah.
Let's do it. Fifth time's the
Fifth
wait.
time the charm.
Okay.
Okay, hang on. Welcome to Tell Me About It. This is the show where I interview various professionals to get insight into their daily lives on the job. I'm your host, Josiah Smith, and today I have a very special guest. This is Tyler Eastep. Tyler is a clinical pharmacist at a hospital. So Tyler, let's start right there. Give me a 2-minute elevator pitch for clinical pharmacist. What do you tell somebody you do if you have just 2 minutes?
Yeah, so clinical pharmacist. So I think that means a lot of different things to a lot of different people. I know most of the time when people hear pharmacist, they think the person in the white coat behind the counter at their corner drugstore, which most of my colleagues in pharmacy, that's what they do by the numbers. But those of us who work in hospitals, it's a little bit different of a group of people we're most often interacting with. So most of my time on the job, I'm interacting with doctors, nurses, other people wearing scrubs, really. So I specifically work in a children's hospital, so sick kids are all I know. And I like to say that I help others use medications to safely and effectively take care of sick children. And that's keeping an eye on pharmacy technicians in the IV room when they're making sterile compounded medications. That's looking at orders that my physician colleagues place on the computer, making sure that they're A-OK. That's talking to my nurses and making sure that they have IV lines that can run all of the medicines that the sick kiddos need. So it's doing like lots of pharmacist jobs. It's doing a bunch of different things with a bunch of different people, but all kind of with the through line of medications.
Awesome. And how long have you been there?
So I've been a pharmacist for 5 years. So I did 2 years of postgraduate training, which we call a residency at a children's hospital on the East Coast, and then I've been out of residency, or so I finished my training, and I've been in practice for 3 years now.
Okay. Is that typical to do a residency? If you're any pharmacist that graduates, um, it's a doctoral degree, so it's like 4 years grad school, post like bachelor's degree, and then everybody goes and does I lost the word residency. Thank you. Sorry. Everyone goes and does a residency if they want to work anywhere other than a drugstore.
That's more or less correct. I know it's not something that's required by the profession. Like our licensing isn't contingent on residency training the same way that doctors are, because they have to do a residency after they finished medical school.
Hmm.
But for us, I think it is a little bit more of a soft requirement, and lots of employers look at it as a requirement, just especially in any sort of subspecialty area, right? Because in pharmacy school, most of what you learn about is sick adults. And again, taking care of sick children does require a little bit more focused training in that area. So at least for me to feel like I could do this job I'm in now effectively, for me, again, my professional discretion tells me it was a requirement. Um, but I feel like lots of pharmacists, most of the pharmacists I would say you would interact with in a hospital setting, likely did a year or two of residency.
Okay, and then let's jump back right there. What is the biggest difference or few differences between your sick adults and your sick children in
Yeah, so
terms
the
of
one
medication? I guess.
right. So a couple of the big differences is there's this really trite quote that we use all the time that children aren't just small adults. So the ways that they metabolize drugs are different. Some drugs um, behave differently in a child's body relative to an adult's. Either they
Mm.
can have an outsized response and that they need a smaller dose, again, like relative to their body size, or in some cases they require a larger dose. So there are some medications. So as an example, your kidneys in young children and adolescents, teenagers, actually work better than adult kidneys. So if you picture adult kidneys fire at about 100%, teenage kidneys fire at about 130%.
Mm.
So that requires a lot of finesse, I would say, in dosing medications for these patients. Also, because of ethical issues, there aren't as many drugs that are as well studied in sick children relative to sick adults. And there
Mm.
aren't, and aside from that, just from the numbers perspective, there aren't as many of them. So there are fewer possible research subjects. So it's a little bit more challenging to get data on these patients. So we're operating a lot more in gray areas in terms of what we call evidence-based medicine. So white papers that are published to support what we're doing. The things that we do are heavily and substantially informed by these our basic science principles, our clinical science principles, but there aren't a lot of the time in adults. There will be a study of 10,000 patients that looked at patients who had a blood clot in their right lower leg. We just don't have quite that amount of data in children, so we're having to again we have a lot smaller of a data set to work from that's informing the decisions we make.
Okay. And so how much of what you know and what you do is directly informed by your experience in school? Like, is that training, do you use your grad school training, is that what you're putting into practice every day at the hospital, or is it almost like you need to have this groundwork and then you get to a hospital and then you learn how to actually be the hospital pharmacist?
Right. The way that I would contextualize it is if you think about like a really tall office building, and let's say you work on the 30th floor. If you work on the 30th floor and your colleagues are on the 29th floor, your boss is on the 35th floor maybe. How important is the ground floor for your day to day? You don't spend any time there. None of the people you interact with regularly are there. You're hundreds of feet above the ground floor. The ground floor is still pretty important.
Yeah.
So I think that it's all whether or not you're leveraging that exact information on a day-to-day basis. I still think the building blocks of getting again to the 30th floor I think are still pretty important. Just as an example of something that we learn in grad school is what we would call like a SOAP note. That's a pretty common, it's an acronym that stands for subjective, objective, assessment, and plan. Just kind of that really structured approach to working through a patient. So if you have a sick kiddo who comes in and is saying, oh, I have a cough, and that's sort of a subjective piece of data that the patient or his or her parent is reporting to you. And then one of your nursing colleagues does a set of vital signs. Oh, this kid's running a fever. That's an objective data point. And you get some more, or the doctor who's talking to them gets some more information. Oh, they have a little brother who's sick at home. Okay, so that's another piece of data that informs that. And then you move to your assessment. So looking at all of the subjective and the objective information, assessing and kind of working through what might be going on, and then you get to the end of it, your plan. What are you going to do with it? And in terms of grad school, it's just lots of putting reps in of those algorithmic standardized approaches to different problems. Then I do think you kind of do have to start somewhere. So lots of that like foundational knowledge, again, that you might not use on a day-to-day basis, but is still kind of your ticket in the door to start learning some more of these sophisticated concepts.
Sure, and that makes sense. Not to get too tied up on one thing, but where does the pharmacist come in that assessment and plan piece when you're at the hospital? Because I would imagine it's a hospitalist that gets final say, right? When you're actually talking about how we're going to care for a patient, or are you heavily involved in that planning, assessment and plan part?
I think we're pretty heavily involved. I know that I'm really blessed to have really collegial relationships with all of the physicians that I work with, and our perspectives are pretty highly valued. The biggest thing, and I think that this is just a key distinction point, is we're not diagnosticians, right? Like we don't have the training or the expertise just to make an appropriate diagnosis, but we spend a lot of time reading studies, keeping ourselves up to speed on different sorts of evidence-based guidelines in terms of how to treat specific disease states in children, which that is helpful and I think pretty critical in developing a treatment plan. And then a lot of the times with some of our medically complex children, I know that I alluded to there aren't that many sick children again, at a population level, but I mean the ones that are most represented in a hospital setting, a lot of the time have a bunch of different medical problems that require medications, and sometimes things don't play nice together, right? Like we talked about, one thing I alluded to earlier was the nurse who has half a dozen different medicines that all need to go through a single IV line. How can we optimize to get
Mm.
that done? And that's something that comes up even after, again, the attending doctor, so the doctor who's finished their training, the resident doctor, so the one who's still undergoing their training, and myself or one of my colleagues have come up with the plan of treatment, and they're saying, yes, this sounds good. This is exactly what this patient needs. And then it gets to the bedside, and it may or may not be achievable just based on, again, like those like the reality on the ground, so to speak.
Hmm.
So again, we're kind of involved in that formulation step, the talking shop with the doctors, and deciding on what the best plan is going to be. Obviously, we're, again, surprising nobody, we're really involved with the actual preparation of the medications in terms of overseeing that that's done correctly, and
Yeah.
then taking it that last mile to actually get to the patient. So I think front to back, we're pretty highly involved in again the care that any individual patient receives.
Okay, so talk me through the organizational chart of where you're at in the hospital. So you've already mentioned nurses, pharmacists, doctors. Like clearly, there's so many moving parts to a kiddo receiving good care. So as best you can, kind of in a simplified way, talk to me about where you fit within that spectrum of care for a patient.
Yeah, so I think like it's kind of two separate things, right? So there's the delivering care on a day-to-day sort of basis. I feel like I'm pretty much, I in the context of like a healthcare team. Um, I'm a willing and capable helper of the attending physician, right? Like
Hmm.
they're running the show. Um, but then in the, again, Tyler, the employee of a hospital
Hmm.
context. So I don't have any direct reports in my capacity. The person that I report to, my supervisor, is a pharmacist by training herself,
Okay.
and just about everybody who's in any leadership capacity in the Department of Pharmacy is a pharmacist by training. Like a lot of jobs, if you advance far enough in the field, you stop doing the thing that you ostensibly trained to do.
Yeah.
So, and it's kind of on the chain when you get to the like more director level, and then typically like more executive hospital leadership. That's I anecdotally I feel like that group kind of skews towards either having a nursing background or being a physician by training.
Okay.
But all of those different, I'd say, like subsets of healthcare professionals, we're all pretty well, like, again, looking at it like the org chart perspective, like you mentioned, we're all pretty siloed from one another. So pharmacists are overseen by other pharmacists, nurses are overseen by other nurses, doctors are overseen by other doctors. Um, yeah, so that's again, the person who does my annual evaluation is another pharmacist, though.
Gotcha. And what sort of things are they evaluating? And this is probably two questions as well. Is what is that evaluation process like in a hospital, pharmacist to pharmacist? And then also, how are you held accountable for not necessarily mistakes, but performance? Like who is saying like you need to do better at this or you messed this up? How does that work in that type of field?
Yeah, so there are two kind of big topics. And I'll tackle the smaller one first. So things that we're evaluated on. I mean, like just like any other job, right? We have a job description that shows like the sorts of responsibilities that you're expected to do, and essentially it's a little bit of a checking the box sort of functionality. Hey, are you safely verifying medication orders? Are you overseeing preparation of medications efficiently? I think those sorts of things. We have goal setting that we do annually, so different sorts of protocols. There have been presentations. I've set the goal before. Hey, I would like to give this presentation on this topic by the end of the year. That's sort of self-directed, and it's sort of fit into like departmental goals. Like we have, we're our hospital has a pharmacy residency program, and we're required to do a certain number of preceptor development hours per year. So that was a goal of mine, was giving a preceptor development talk. So that serves both. That's an opportunity for me to develop my presentation skills, and that's also serves the needs of the hospital in terms of, hey, if we're going to have this program, we need to make sure our people are adequately developing their skills at teaching people how to be pharmacists.
Yeah.
So that's a case where I think the evaluation, the door swings both ways, so to speak. And then, so you pivoting kind of from the more like rote employee evaluation piece of things to accountability, right? Mm-hmm. So a thing that we talk about a lot is medication safety, right? Again, in my elevator pitch, safely and effectively.
Yeah.
And the safely comes first, I think, pretty purposefully and pretty importantly. So a illustration that we talk about a lot in healthcare is something we call the Swiss cheese model. So if you picture everybody in the between the patient and everything between pretty much the patient and like the good care, right, is a slice of Swiss cheese. So you have their physician, you have the attending physician, you have the resident physician, you have the nurse, you have the pharmacy technician, you have the pharmacist, and if there's ever anything that's missed, it might make it through a slice or two of that Swiss cheese, but again, the thought is that there are enough redundancies built into the system of care that one of those is going to catch the to catch the error before it reaches the patient. Mm-hmm. But occasionally, unfortunately, all of the holes in the Swiss cheese are going to line up, and that instance of harm is going to reach the patient. And I think a really big thing that's a big emphasis in healthcare in terms of accountability is that the focus when in sorts of patient harm events is improving processes, not punishing people. Because if the entire system rises or falls on one person doing their job perfectly, that's not a well-designed system.
Right.
And this excludes sorts of cases of like gross negligence or sidestepping safety parameters. But even that's a case, right? If there's a system that is intended to keep people safe and staff are circumventing it or stepping around it, why is it that they're stepping around it? Is it somehow less efficient? Are there ways that system could be improved? So I'd say that in terms of accountability, everybody's accountable for doing their piece, their Swiss cheese, having as few holes in it as possible. Mm-hmm. But at the end of the day, I'd say that the culture that we try to cultivate in healthcare is one that, again, we're even competent professionals can make mistakes. And again, looking at ways to make systems as safe as possible so they're not just, again, kind of accounting for the reality that to err is human.
Yeah. Oh, that's good. Have you noticed, because you've done the grad school thing, I imagine there's plenty of time spent in hospitals there. You did your residency program. Now you're at a hospital. Have you noticed, because you keep using the term like in healthcare, we XYZ. Have you noticed that there's a lot of commonalities at hospitals, or does it vary a lot when you're talking about culture and processes? Is that pretty standard across like most hospitals, or does it really come down more to like the leadership at that hospital and how well the machine runs?
I think it's some of column A, some of column B, right? Like there are professional organizations that have issued like guidance documents, best practice recommendations on, hey, you really should be doing things this way. So a big one that we talk about in pharmacy a lot is called ISMP, or the Institute for Safe Medication Practices. So there was this big case in the news a number of years ago where a nurse inadvertently um, from a medication cabinet was able to obtain a drug called a paralytic, so a medication that essentially makes it so none of your muscles work,
Mm.
including your diaphragm.
Mm.
And in a patient with a breathing tube who's connected to a ventilator, so a machine that's breathing for them, that's something that can be done safely. But this was inadvertently administered to a patient who did not have a breathing tube in, and unfortunately, this patient ended up passing away. And the staff member who obtained the medication and inadvertently administered it to them received prison time in the course of the
Oh wow.
the case, the way it was adjudicated in the courts. And this was something that, in talking to colleagues of mine at various hospitals, pretty universally, everybody agreed. I could absolutely see that happening in the hospital where I work.
Mm.
And one of the reasons and the reason I bring that up is there's a specific best practice that this organization has issued to prevent this from happening. So, whenever in one of these medication cabinets, which has like a keyboard and a computer hooked up to it, the recommendation is you need to type at least three letters in before it'll show you a list of drugs to obtain. And it was a difference of a difference between one V drug from a different V drug,
Mm-hmm.
because this best practice hadn't been implemented.
Mm.
So the systems are only the patients are only as safe as the systems are. And again,
Mm-hmm.
I think this was a case of where the patient was harmed again as a consequence of a system that was not designed for their own safety.
Yeah.
So I think, like, with regards to circling back to, again, like, standardization, some of those, like, safety processes, I think more and more there's a move towards standardization
Mm.
for those. Again, in terms of, like, the clinical medicine, so the why we use drug A versus drug B, right? Like, by and large, a sick child in New York is not that different from a sick child in California,
Yeah.
right? So that the clinical side of things, I think there's play in the joints a little bit, but by and large, the medicine is about the same. But then in terms of implementation, there are two really large electronic medical record systems, and your individual working experience and kind of how the workflows are built up around either of those will be vastly different based on which
Mm.
which computer system. Think of it, it's like the operating system of the hospital. So,
Okay.
right, like if you're primarily in a Windows sort of office versus a Mac OS sort of office, like, there are going to be differences reflective of those two things. So
Yeah.
you'll see that an Epic hospital is a lot different from a Cerner hospital, for example.
Okay. Interesting. And those are the two programs, Epic and CERN.
Yeah. And I mean,
Interesting.
like, there are like Linux equivalents here and there, but but by and large, those are the two big ones.
Okay. Cool. So walk us through day to day. So take me from clocking on to clocking off in a single day. Tell me what you're looking at, who you're interacting with, and how it all comes together.
Yeah. So I have a little bit. My role is, even again, to further differentiate myself from a hospital pharmacist, I work in the evening, so I get I have kind of a foot in both camps in terms of day shift and night shift medicine. So I get to the hospital at about 3 o'clock, and I'll during those couple hours of overlap with my day shift colleagues, I chiefly serve as an extra set of hands. So checking in with if there are any sorts of dispensing distribution activities. So getting medicines checked to get out the door to a patient floor. Do some of that. Again, kind of boring, uninteresting employee things like catch up on emails.
Sure.
And then another that can take any any amount of time. Again, we have learners, so either pharmacy residents or pharmacy students. We typically have presentations in that late afternoon time, so attending presentations. That's another pretty common activity in that first chunk of my day. And then, sort of as my day shift colleagues are leaving around 5 o'clock or so, they will alert me of any sorts of. I like the kind of the three categories of sign out that I'll receive from them are anything that requires active follow up. So if there's a drug level that they're expecting to come back at 9 o'clock, following up on that and making any adjustments, touching base with the medical team who's taking care of that patient, sorts of active follow up activities. Any sort of what I call like a high risk, low use medication. So a medication that we don't use a lot that carries with it some sort of particular risk, or maybe not a risk, but just a quirk. Like, hey, make sure the nurse for the patient in bed 2 knows that this bag has to be changed at 2200. Things like that. And then the last thing is patients who are watchers. So if a patient on the floor, so outside of the ICU, who might be at risk for getting sicker and needing to go to the ICU, things like that. So, and then once they leave, it's we have a little bit more delineation of responsibility during the daytime. So there's one pharmacist for the pediatric ICU. There's one pharmacist for the hematology oncology floor. Pretty much after the day shift crew leaves for the day, I'm everybody's pharmacist. So which I really like, because I have a pretty broad interest area in pediatrics. So I like getting to help take care of everybody.
You get to see a lot of different. So what, and I imagine too, there's probably not as many drugs being administered overnight, with the exception of like your IV stuff that has to be like constantly metered in. Am I right in that, or is it, or no?
So the one thing to keep in mind too is but in the ICU in particular, but also in the hospital in general, lots of patients will have a feeding tube in, either a feeding tube that's like surgically placed, or what we call like a nasogastric tube, or a tube that goes through your nose into your stomach. You don't have to be woken up to be given a medication by your NG tube. So that is one other.
That's kind of wild.
Bananas, right? So that's another consideration, is we give meds through sick kiddos' tummies at all hours of the night.
Yeah. That's really interesting. And do you, because again, there's just so many variables, I guess, that come into it when you're talking kids. Do you have to get consent from parents every single time you administer a new medication, or do they come in and are like, hey, we're doing the best that we know how to do to take care of your kid, so we're gonna do that? How does that work?
Yeah, I think that's a really interesting question to bring up, and I totally understand the sorts of way that parents.
I guess I should say guardians.
Parents or guardians.
Yeah.
I mean, parents most of the time, but guardians advocate for their hospitalized children.
Mm-hmm.
And I think it's important that one of the most important things that I think that parents should know is that nobody cares for your kid more than you do.
Right.
There are people who, in again a knowledge training perspective, do know what's best for your kid better than you do.
Sure. Okay.
And I think that it's really important. I think that sometimes parents will try to be their kid's nurse, be their kid's doctor. They need you to be their mom or dad or grandma or grandpa. They don't need you to be their doctor, because they have a doctor who's doing their level best to take good care of them.
Yeah.
And I think that that can be a challenging thing for parents, right? Is that
yeah.
Just because you, like, by a country mile, you care about them more than we do.
Yes.
But we promise we're trying to take good care of them, and we really want you. We want the opportunity to earn your trust in doing that.
Right. Yes. Like, okay. Because obviously I would give my life for my child. You're not about to go die for every patient that you have, but I assume, and I'm actually going to ask you to do this, you could explain the specific differences between ibuprofen and Tylenol, and I can't do that.
That's exactly right. I think that um, I think that's about right, and um, I think that both sides of that child's care team, the one side being the guardians and one side being the medical team, I think we both do the sick kiddo in the middle a disservice when we lose sight
Sure.
of that dynamic.
Yeah. Yeah, that's interesting. So we kind of got on a rabbit trail there. Is that mostly like how your shift goes then? Now you're just looking at medication, signing off. Because it's, correct me if I'm wrong, it's pharmacy techs are the ones that are counting the pills, right? And you're just saying like, yes, that's the drug that we want them to have.
Yeah, so it's pretty it's kind of again I rattled off some of the activities that I do at the top of the hour, but um, so it's sort of doing those things as they come up.
Hmm.
Essentially, there are a couple like prescribed, like I know that I'm going to go on rounds with the PICU team at 9 p.m.
Okay.
ish.
Yeah.
But aside from that, it's doing a lot of those things as they come up.
Okay.
Um, which I mean, it requires being able to pretty effectively pivot between
Hmm.
tasks. Um, being
So are you
able to
sitting at a computer a lot then? Is most of that stuff, I mean, everything's digital now, right? Like they send stuff across your desk as it were, and you just like look off, sign off, approve,
yeah that
counter, whatever.
yeah that's about right. So there are a couple different queues. So like rolling lists of medications, either orders that are coming from physicians. Um, are the in the IV room we have a software hardware setup that allows the technicians to take really high definition photos of the different steps in them preparing like a bag of IV medication, so they can
Hmm.
see like exactly they reconstituted this vial correctly, they drew up 4.5 mLs of the resulting reconstituted drug and put it in a 100 ml bag of saline.
Hmm.
So one queue for the orders, one queue for the compounding checkoff. And then also there's like a secure like instant messaging program that we use to like quickly like communicate with one another as well.
Interesting. Interesting. So, I told you I was about to ask you this. Give me an example of something that like of where your expertise matters. Like what is it that that I couldn't Google and then show up at a pharmacist and pretend to be a pharmacist? Does that make sense? How do drugs work?
Right, right.
Let's go there.
I feel like that's one thing that a lot of the time when people who don't work in healthcare, you're like, oh, hi, I'm Tyler. I'm a pharmacist, and a lot of the time, the first question is, oh, so does that mean you know all the drugs?
Yeah.
And I'm like, and that's always one that I have a little bit of a hard time with, is because it's not just that that's a bad question. It's
Uh,
that it's built on so many poor assumptions that it's really kind of it's challenging to unpack all of the different ways that that doesn't explain what I do on a day-to-day basis. Of course I don't know all the drugs. We
right.
we look stuff up constantly,
Uh-huh.
because again, like the same way that like we can't a system can't rely on one person being right every single time. I can't rely on my own memory to always know the right answer. Like,
Mhm.
well, I think that that's one thing. And again, to we'll get back to the impress me question, uh, but yeah, I think that the yeah, they're just I think people in the same way that like I feel like my father's an engineer by training, so he's a civil and environmental engineer. So like lots of what he does has to do with like mitigation of environmental effects from like industrial processes. And it would be like if I couldn't get past the fact that he didn't work with trains because he's an engineer.
Right.
right? Like I think that people have a hard time like decoupling their corner drugstore pharmacist from what somebody does on a day-to-day basis,
Sure.
um, bringing it back. So one time I was bringing one of my kiddos to the one of my personal kiddos to the urgent care because we thought he had an ear infection, and we were walking up and I was bringing my oldest tagging along, and she understands that I'm a pharmacist and I take care of sick kiddos at the hospital, and she was asking me, she was like, Dad, when they take Elliot in to get his for his ear infection, are they going to give him a shot? And I'm like, well, no, they're going to give him some medicine, and in the back of my head I know exactly what medicine they're going to give him. I know exactly how often and how long he's going to be on it.
Yeah.
And I tell her they're going to give Bubba some medicine and it's going to help his ears feel better. And she looks at me and she's like, Dad, how much do you know about ear infections? and and I'm like, kiddo, you have no idea how much I know about ear infections. And in the back of my head, they could give him a shot for the ear infection.
Right.
They're not going to, but they could.
They could. Oh, that's funny. So then so take us into that world a little bit more. What's something that you observe and experience in your world as a pharmacist? And you could even be as specific as, caring for sick children, that most people, that civil engineers, that software engineers, that teachers don't realize or notice. Like, what's something that you are sharp on?
I think and again, kind of, this is, you'll forgive the self-interest here a little bit. I think people don't realize how involved in care pharmacists are in the hospital specifically, right? And I kind of gave a little bit of a rundown of this earlier. So again, pretty much from the moment they're hitting the door, there's probably going to be somebody who comes in and talks to you. Oh, what medicines do you take at home? And that list of medicines that you give them, and again, on the sick kiddo side of the house, there's a lot of the time it's none, right? Mm-hmm. But there's going to be a pharmacist who checks off on that. Make sure that all of your medicines are started if it's appropriate for them to be restarted. Right? Like if you're in the hospital because your blood pressure is too low, we're probably not going to want to restart your medication that lowers your blood pressure.
Right.
So, in lots of rounding teams, so in the morning when the medical team comes around and talks about any concerns, kind of makes a collective plan for the day, that rounding team is typically going to have a pharmacist present who's making recommendations, kind of talking with the doctors, making sure that that's all teed up and ready to go, kind of throughout your day. If there are any, again, drug levels, if you're on a medication that requires checking levels in your blood, the pharmacist will lay eyes on those, make any sorts of recommendation to the medical team on those sorts of adjustments. And when you go home at the end of the hopefully brief hospital visit, get the brown or white paper bag with a refill of all of your medications on it. It was a pharmacist who made sure that all of that, if there were any adjustments that needed to be made from your hospital stay, there's a pharmacist that laid hands on that. It might be a pharmacist who's bringing it to your bedside too. And then all of that, every single medication that you received during the course of your hospital stay, a pharmacist was verifying, giving that the thumbs up, and making any requisite adjustments with the involvement of the medical team, including the IV fluids you got. So it is really a like soup to nuts involvement in the medication side of a hospital stay.
Yeah, interesting. That's really interesting. So most of us who, especially who have kids, but even everybody who goes to the doctor regularly, from the consumer side, we can see, or at least can sense, the amount of influence that the insurance companies have on the we'll say like pathways of care that that doctors provide to people, and I'm talking more specifically like your normal doctor's visit. I imagine it's the same in the hospital. Do you see as a pharmacist that having any impact on how you do your job, or is that more of a physician side thing that they must consider?
Yeah, on the hospital side of things, there are sort of edge cases where it influences things. Another thing to keep in mind, and I think people don't realize this, especially I feel like the popular press talks a lot about medication costs in terms of like burden to the healthcare system.
Sure.
When you look at like a typical hospital stay, drug costs in the overwhelming majority cases are typically a pretty small proportion of that bill that they send you at the end. So the more costly parts are going to be any sorts of like procedural time. So if you had to go under anesthesia, like just the presence of the anesthesiologist, the surgeon, like their time is very valuable.
Yeah.
You occupying a room or a bed in the hospital, that's very costly. So in a lot of the medications, and again, there are some exceptions to this, but by and large, the medicines that we use in the hospital are relatively inexpensive compared to other medications. And again, like those really like high cost medications, if you the sorts of anything, pretty much anything that ends in MAB, which is a type of monoclonal antibody. So these really expensive targeted medications, and then obviously anti-cancer, so chemotherapy drugs. Those are also like those are kind of our high dollar items, so to speak. So that I think that's kind of more so where like the cost aspect of things comes into play for as far as drug medication cost.
Is there ever a case where you have to consider the cost of a drug before you sign off on it, or are you just thinking this will take care of the patient or as best we can see?
If there's any way we can anticipate it, we try to. So
Okay.
the person who's a step or two above my supervisor has been given the ability to give the thumbs up or the thumbs down to some of these kinds of things. So if in any way, shape, or form able to anticipate it, typically giving a heads up. And the other consideration too is that it's not. In a lot of cases we do, but in some important cases we don't. We don't just keep the medication on these really expensive medications on the shelves.
Right.
So if there's any sort of like supply acquisition that needs to be done ahead of time, obviously that's preferred. But if it's something we have, and if it's something that the situation requires, cost really doesn't come up in the moment.
Interesting. Can you recall the most expensive drug you've ever dispensed?
There are a couple of these really novel medications that are used for like genetic disorders. So it's the sorts of drugs that they do stories about on the Today Show. That cost upwards of $1 million for a single dose.
Okay.
So a couple of those like gene therapy medications, those are the sorts of ones that clear the like. There's a big email with many important people on it that gets sent out in advance of those sorts of things. But again, these are very planned use of these medications. It's not something that's just going to come up again at 12:30 at night when I'm the one who's there.
Sure.
Fortunately,
yeah, that makes sense. Okay, well, just satisfy my curiosity really quick as best you can. I know you're more on the clinical side as opposed to like the academic or teaching side of it, but on as surface level as you care to go or as deep as you care to go, how do drugs work? What's the if I have a headache versus my knees sore in the morning, I take a pill, it magically goes away. What's happening inside my body that says that little red pill I took is going to make me feel better?
Yeah, so there are kind of two. So that all kind of falls under the heading of the science that we call pharmacology.
Okay.
So there are kind of two arms to pharmacology. There's pharmacokinetics, which is what your body does to the drug.
Okay.
And then there's pharmacodynamics, which is what the drug does to your body.
Okay.
So pharmacokinetics, that's that is how we kind of describe a lot of the major differences between sick children and sick adults. So
Okay.
the different parts of pharmacokinetics. There's an acronym that we use called ADME, so ADME. Um, so that stands for absorption. So how the drug gets into your bloodstream. So that's either through your skin, that's through your GI tract, that's under your tongue. Then there is distribution, so that once the drug is in your bloodstream, or all of the places it can go. So
Hmm.
does it distribute into fat tissue? Does it distribute into muscle tissue? Does it distribute to the proteins that are circulating in your blood? So all of the different places the drug can go. Then metabolism. So how is the drug broken down? That's most of that is done in your liver. And then lastly is excretion. So how do your excretion or elimination? So how your body gets rid of the drug, and that's chiefly going to be through your kidneys.
Okay.
So lots of those. There are very specific differences we could go into between sick children and sick adults, but lots of our differences can be described under those four kind of subheadings. So then pharmacodynamics. So what the drug does to your body. So if you if you think of like a drug like an antibiotic, like amoxicillin, again, that's
Hmm.
a frequent flyer in children's hospital land. That's the
My
drug that they
children
gave.
have had it before. Yeah.
Yeah, that's the one they gave my son for the ear infection.
Yep.
Um, Amoxicillin, it's a beta lactam antibiotic. So what it does, it binds to a specific protein in the cell wall of certain types of bacteria. And when those bacteria go to divide, essentially they turn themselves inside out.
Hmm.
So it's what we call a bactericidal antibiotic. So it kills the bacteria side, like homicide.
Yeah.
So it's going to actively kill um, the bacteria. So that's like just one example of like what a drug does to your body. And in that case, right, like the target of the medication is not one of your cells.
Okay. Yeah.
Right. So another example would be albuterol. So I have asthma, like the blue puffer um, that I take whenever I'm feeling wheezy.
Hmm.
So when you inhale the medication, it attaches to what are the beta receptors in your airway tissue, and essentially it's an agonist, so it activates those receptors, and it causes the smooth muscle, so muscle that you don't have voluntary control over in your
Hmm.
airways, to relax. And because it permits the air to flow, what we call like a laminar flow, so flowing in kind of a straight flowing line versus turbulent flow, which is like twisty twirly flow.
Hmm.
You can get oxygen into your lungs better, and then you can breathe better.
Hmm.
So again, that would be like a the pharmacodynamic piece of albuterol would be, hey, it gets into your lungs, it activates those beta receptors, and it opens up your airways. And then the kinetic piece of things, it doesn't have a very long half-life, so it doesn't last very long. So
Hmm.
sometimes you have to, if you're feeling particularly wheezy, you might have to take it again. And if you're having to take it too many times, probably it's a good idea to go get checked out at the emergency room.
Interesting. Interesting. So, um, drug development, like we obviously don't have time to get into like how did they make albuterol, but does that fall in the same field of pharmacy, or is that a completely different biology, microbiology, all that?
Yeah, I'm the wrong person to ask for that one. I know anecdotally, so lots of the people who are involved in drug discovery and development are going to be people who are PhD trained, so have
Mm.
much more experience with what we call like benchtop research. So
Okay.
if you see somebody with a petri dish and a micropipette,
Yeah.
that sort of work. I know occasionally there are people who have a pharmacist background who work in those fields, and that's either going to be through a university or working for a drug company.
Okay.
So, um, once they've put the data in a published manuscript, I can tell you a lot more about it. But in terms of how it gets from the an idea that a scientist had to a medication that a human being actually received, I'm probably not the best person to ask.
Yeah, you're that next step
Right.
that comes after.
That's right.
Okay, cool. Cool. Well, we're about out of time here, so let me ask you my bonus question, which is, what gets you out of bed in the morning? What makes you do what you do every day?
Yeah, so I love my job. I really enjoy and get a lot of fulfillment about what I get to do. I work with a really amazing group of people. Again, I think the taking care of sick children is a really high yield profession, because you're in my mind, you're not just taking care of the sick kiddo, you're taking care of their whole family, right?
Yeah.
Like getting to see a kid turn around over the course of a hospitalization. It's moving stuff. Um, and I would encourage anybody who's considering any sort of profession. I think it's important that you do something you enjoy and something that fills your cup and something you're good at.
Mm.
But man, I'm going to encourage you to try and find some other stuff to get out of bed besides just what pays the bills. So
Yeah.
I like cooking for my wife and kids. I like exercising. I like playing Dungeons and Dragons. I like reading good books. And I like getting to know Jesus better. And I would say those are all of the things that get me out of bed in the morning. And as a bonus, I get to do a really cool job.
Yeah. Awesome. Cool. Well, I appreciate it. We didn't have time to get into nightmare days, perfect days, the full work week. So we might have to have you back on the show at some point, but I appreciate you taking the time this evening.
Yeah, it's been fun. We'll talk soon.
All right. That's Tyler Eastep, clinical pharmacist at a children's hospital. Thank you, Tyler.